typically, occlusion is broken into two parts, the anterior determinants and the posterior determinants. Most of the time we hear about posterior determinants. So this is the condyle disc assembly in the fossa. This is the tooth morphology, how teeth come together and come apart. But really, just as equally important is our anterior determinants. Now, anterior determinants can be broken down into two parts. The aesthetics, the aesthetic A point, how long are the teeth? How much do they show? Our smile design. But what I'd like to focus on today is the lingual surfaces of our anterior teeth, because these are essential for disclusion as well as working within harmony of the envelope of function. The lingual surfaces also help with phonetics, but we're not going to go into that today. We're just going to talk about function. So let's start with some definitions. And I want to start with the definition of anterior guidance, and this is as it's defined in the Journal of Prosthodontic Terms. And if you'll excuse me for a moment, I'm actually going to read it so I get it right. 1, it's the influence of the contacting surfaces of anterior teeth, limiting mandibular movements. 2, the influence of the contacting surfaces of the guide pin and the anterior guide table on articulator movements. And 3, the most important, the fabrication of a relationship of the anterior teeth preventing posterior tooth contact in all eccentric mandibular movements. In other words, how do we get the anteriors to help us separate the posterior teeth to eliminate off-axis loads and shear forces which are detrimental to our teeth and to our restorations? So there are a couple of terms that are out there that are kind of confusing. Envelope of function, or is it the envelope of motion? And, even I find this confusing. So I'm going to give you my take on this, and hopefully it'll be a little bit clearer to you. Envelope of motion is basically anterior guidance. Okay? This is an inside-out movement, and it's designed to separate the posterior teeth. Understand, this is a border movement. Okay? Now, envelope of function, now this is the path that lower incisors will travel in an outside-in motion, and this occurs during chewing, speaking, and closure. So envelope of function occurs within the envelope of motion. But it's essential to understand, and this was taught to me by Russ DeGroot, that the mandible travels away and back towards centric in parafunction and in chewing following the exact same pathways. And Russ demonstrated this beautifully in his wax-up. You can see that protrusive is in black, lateral obtrusive in yellow, and lateral movements in blue. And so we need to understand how things work. So let's again focus in on definitions, and this is from the Glossary of Prosthodontic Terms. Envelope of function, the 3D space contained within the envelope of motion that defines mandibular movement during mascatory function and phonation, so chewing, speaking. Envelope of motion is the 3D space circumscribed by mandibular border movements, the border movements, within which all unstrained mandibular movement occurs. This is also known as poselts. So if we put on our student cap and our enter the Wayback Machine where we learned about poselts, it's important to understand that the most superior portion of poselt's envelope is determined by tooth contacts. The remaining border movements are determined by the joint anatomy. So when we see the movement of the top part of the envelope, we see go from CR to MIP, then to edge. These are all tooth-driven determinants, and we need to keep that in mind. So, when we go back and look at where some of these great occlusion studies came from, Lundeen and Gibbs were pioneers. They studied the function of teeth, and they did some incredibly detailed studies where they would actually attach clutches to teeth on the buccal surfaces so that the teeth would still occlude and people could chew and eat, and hang these little sagittal flags and trace poselts. Then they would take these same patients and they would give them different types of food of different textures and consistencies and have them chew them and look at the envelope of function. But what they found, which is really cool and really interesting, is how they chewed. Was it a more vertical chewing stroke, envelope of function, or was it a more horizontal, more likely to have posterior interferences? And what Lundeen and Gibbs found, that your chewing cycle, when there were no posterior tooth interferences, was more vertical. When there were posterior tooth interferences, when there were centric slides, the chewing cycle became much more horizontal, more likely to bang into the front teeth in the chewing closure stroke. So posterior teeth do have an effect on anterior teeth, and anterior teeth have an effect on posterior teeth. In other words, centric interferences can cause erratic contacts on our anterior teeth during chewing. Now, if we go back even further and you remember Hanau's quint, and Hanau's quint is kind of getting lost because Hanau's quint was designed to help us create dentures with full balanced occlusion. So we could follow the formula that took into account the condylar inclination, the incisive angle, the occlusal plane, the heights of the cusp, and we could vary all of those until we achieved our goal of balanced occlusion. But we can also use Hanau's quint to help us with a mutually protected occlusion, where the posterior teeth protect the anterior's enclosure and the anterior teeth protect the posterior teeth in lateral movements. So if the incisive angle is less than the condylar inclination angle, you're going to have a posterior interference. And of course, that's not what we want. That's bad. However, if the incisive angle is much steeper than the condylar inclination angle, this allows for not only translation, but also rotation to help take the back teeth apart. So you get faster separation of the back teeth, and this is a good thing. Now, the question is, if that's a good thing, if you steepen the anterior guidance to get faster molar separation, well, why don't we just crank up the anterior incisive angle? Well, maybe we can, maybe we can't. So fortunately, through the good work of the late Bill McCorris, what Bill did is for a full year in his practice, he took models of all his patients, mounted them onto a semi-adjustable articulator with a face bow, took a protrusive check bite to set the condylar inclination. And then he had this wonderful little protractor made, this little doohickey thingamabob right here, where he could actually measure the incisive angle and write it down. And now what Bill did was rather brilliant. So once he had this information, he went ahead and basically made little slip-on Essek types appliances with steeper and steeper incisive angle guidance. So he made the incisive angle guidance up to 15 degrees steeper, and then 10 degrees steeper from what they started with, and then 5 degrees steeper than what the patient started with. And what Bill found is that nobody tolerated the 15 degrees steeper. They were just kind of locked in. They didn't really like the feeling of that. A handful of people tolerated 10 degrees steeper incisive angle, but everybody tolerated 5 degrees steeper. So Bill concluded from that the ideal disclusive angle should be 5 degrees greater than the condylar inclination angle, and this would allow for a little bit of rotation and faster separation of the posterior teeth.